Thank you. So, so we're now thinking in this session about moving from evidence to action. So what's it going to take us to get us across the line? So we've got four great speakers in the session, and then after the short presentations, then we will have a panel discussion at the end. So we'll first hear from Michelle Groome about ongoing work on the Myrna Consortium, which has brought together 9 partner countries from the Global South with the aim of accelerating preparation for maternal immunisation introduction, including both RSV and future GBS vaccines. We'll then hear from Martha Mandale, who will tell us about safety surveillance systems for maternal immunisations. And as I think we saw earlier from the both Kirsty mentioned in her talk, but from the Menti, back earlier in the day, we saw, I think this was the number one factor safety that came up in terms of single points of importance. We're then going to hear from Ignacio Esteban with a update on the financing on Gavi-6 and the implications that this might have for GBS vaccine introduction. And then last but very much not least, we will hear from Violet Naanyu about the prioritising equity in maternal immunisation, tackling barriers to access. And again, I think we've heard it echoed several times already that really acceptance amongst pregnant mothers is going to be a very key element of bringing this vaccine into fruition and having the impact that we hope that it has. So I'd like to start by inviting Michelle Groome. So Michelle Groome has 20 years experience in the field of infectious disease and vaccinology. She's a principal researcher in epidemiology and a technical lead for Maternal Immunisation Readiness Network in Africa and Asia. And she's going to be giving us an update on the work that the consortium's been doing. Thank you, Michelle.
Great, thanks, Simon. So I think you've heard a little bit about our consortium, but then this is really just to give you an overview of the work that we've done. We're not really presenting any data today, although there are some posters up around of some of the early work that's coming out of Myrna. So yeah, just wait for the slides. There we go. And so this really was born out of trying to raise the voice from the Global South. Let me grab that. All right, so we know, maternal immunization is not new. And so kind of why are we really worried about maternal immunization readiness? Tetanus has been very impactful, seen big reductions in neonatal tetanus. But really, the introduction of these new vaccines is really something we need to pay attention to, particularly in low and middle income countries. And these vaccines are being developed specifically for use in pregnant women. In these contexts, the timing of vaccines is slightly different with these specific vaccine windows that have been used during pregnancy. There's heterogeneity in how vaccines are provided, some countries using their expanded programs on immunization, others using antenatal care, others using campaigns. And it really is going to take collaboration for vaccines to be successfully introduced to make sure that the uptake is good and that we have good coverage, especially in low and middle income countries. And this is really kind of trying to raise up leaders from the South. We've seen that there's been significant delays in the introduction of new vaccines in low and middle income countries compared to high income countries, sometimes up to a decade, where we wait for vaccine introduction in kind of low income countries. And so really trying to generate kind of country-led advocacy and leadership from the Global South, and particularly related to maternal immunization, a unified approach to strengthening these platforms so that we can ensure early adoption, build and expand existing efforts. There's a lot being done in terms of maternal immunization. We're not trying to reinvent the wheel. We're trying to use what has already been done and adapt this to our context. And so advance the body of evidence needed to support global strategy and policy recommendations for maternal immunization. So the Maternal Immunization Readiness Network in Africa and Asia, or MIRNA, is really to identify, characterize, and support the platform, policy, and preparedness requirements for the introduction of new vaccines. And really what we're asking is kind of how do we systematically assess readiness in a way that can be adapted for other countries in future if countries are wanting to introduce these new vaccines. What evidence is actually needed for those decisions made by policymakers, and how do we package that in the best way to assure that we can facilitate this adoption? So currently we're a consortium of 9 countries with WITS Vida, based in Johannesburg, South Africa, as the coordinating institution, and we have countries from both Africa as well as Southeast Asia, led by myself and Helen. So really bringing together countries with different ways of providing maternal vaccines, different platforms, as well as different geographical areas, and really bringing expertise in maternal health. So all these countries have strengths in various areas, and really the aim of the consortium is to leverage on these strengths to really be able to advance a vaccine introduction. But it's not just these countries. I think we really have expanded and trying to include as many as we can in terms of stakeholders. So both collaboration with global organizations like WHO and Gavi, working with other partners in this space. Our technical advisory committee is really including, very inclusive of these different partners. And I think really importantly is working very closely with the governments in these countries, specifically with the NATAGs, and all the country partners have really established very close relationships with their governments and with their NATAGs, really including the NATAGs and NATAG chairs in many of our meetings, and so really engaging early on, way before these vaccines are actually available. And so there's 3 focus areas for the consortium, really, one being the vaccine investment. So producing the evidence in terms of burden, cost effectiveness, and budget impact, as Simon's outlined, kind of really what's needed for decision makers to support this, and that we can really provide a compelling case for introducing these vaccines and LMICs. Looking at the health system, how ready the health systems are, so that we can really ensure successful delivery, and so developing strong antenatal platforms that are really integrated with EPI. And then on the vaccine demand side, assessing community readiness for maternal vaccines, really to look at the drivers and barriers of access and uptake, and together with the government partners to really develop country-led national vaccine demand strategies. So this is just one of our pictures that were drawn at our latest meeting, and I think really just shows the different work packages with the burden of disease, producing new, or consolidating data on burden as well as surveillance systems that are available, health economics, looking at cost analysis, putting together cost effectiveness data as well as budget impact analysis in some of the countries, situational analysis, really using existing tools to try and have a look, how, understand the landscape and see what's needed, seeing whether countries are ready, are they not ready, are they almost ready, and what additional things need to be done to ensure that countries are ready. And then from vaccine demand to just hear the voices from the communities, from different leaders through mixed methods research, and then trying to use that in terms of generating actionable insights. And so working together with ERIMI, with the 6 A's approach for countries, we are conducting user-centered design workshops in each of the countries to really have these country-led vaccine demand strategies. And then providing a toolkit which can then be used in other countries that are wanting to introduce these vaccines. And so one thing, the set of tools that can be used, as well as the data that's been generated for policymakers. So just a little bit of more detail in terms of those different work packages. So we've developed protocols across all the work packages which can be adapted for country use. So systematic reviews to be able to assess the burden of RSV and GBS, scoping review to understand the surveillance platforms that are available or could be leveraged once these vaccines are introduced, and we want to do impact and effectiveness studies, looking at costing and budget impact analysis. So all of these will be able to obviously generate reports as well as these tools which could be adapted in other countries. The situational analysis using different tools which have been used, including WHO materials, the facility readiness tool from JPAGO, as well as the vaccine trust indicator, to assist countries to grade, whether they're red, really not ready, orange, where they would be able to introduce with some kind of additional inputs, or whether they are ready to introduce. And once again, also producing toolkits and these tools which would be available. And then from the vaccine demand, really mixed methods research, interviews with moms, community leaders, providers, policymakers, and surveys to really inform the demand strategies. And so really looking at all the components which need to be optimized in terms of generating readiness. And at our last meeting, or at our meeting last year, we really got together with policymakers in each of the countries, and really just trying to understand what is needed. And so I won't go through kind of all of those, but really in terms of making sure that we include the relevant stakeholders, all the decision-making structures, trying to really raise awareness. So I think that's come out as a big need in terms of raising awareness for RSV and GBS. And then really looking at financing. Ignacio is going to speak to a little bit of that, engaging professional bodies and associations. And I think this is really in terms of longevity as well of the consortium. I think trying to raise up people from within, advocates within the professional societies, especially obstetricians who maybe haven't previously been really involved in terms of what happens to the neonates and children. And so really are trying to put together all of this, and hoping that we would be, the work that we have done will obviously inform the in-country uptake and adoption of these vaccines, but also to provide the tools to enable other countries. So I think I'll stop there. Just wanted to show that was our last meeting. We do have a website, and I think look out for some data coming out from the consortium.
Great. Thank you very much, Michelle. Yes. Thanks. Next, I would like to invite to the stage Dr. Martha Mandale. So Martha is the Principal Regulatory Officer at the Pharmacy and Poisons Board, which is Kenya's national regulatory authority. She's worked on pharmacovigilance and vaccine safety, supporting the regulation and post-authorization monitoring of maternal and neonatal health interventions. And she's now going to talk to us about GBS and vaccine safety surveillance. Thank you, Martha.
Thank you. Good afternoon, everybody. Okay, we don't sound so energetic. Good afternoon, everyone. I know I stand between lunch and yourselves, so it would be encouraging to see some energy from up here. Karibuni sana tena, Kenya. Okay, so I'm going to touch on safety surveillance for maternal vaccines. And the outline of my presentation includes the importance of the vaccine safety surveillance for maternal vaccines. Understand what the objectives for maternal vaccine safety surveillance are, the types of safety surveillance systems that we could use. I think there's a presentation that we saw earlier touching on this. What are the challenges of safety surveillance? What are the opportunities? And of course, I'll delve in a little on a maternal immunization safety surveillance project that we are currently planning on. We're saying we are moving from evidence to action, right? And I think I put it off. Okay. Yeah. So I think most presentations have covered this. We appreciate that maternal vaccination reduces morbidity and mortality from vaccine-preventable diseases in pregnant women, their fetuses, and of course the infants. And just looking and appreciating the data that is there from systematic reviews from WHO, we appreciate that there are 200 million women who become pregnant each year globally, and a big percentage is actually in the LMICs. There's increased use of maternal vaccines. We have the influenza, we have TD, TT. At the height of COVID, we had COVID-19 vaccine. We have the RSV that is picking up, and of course the GBS vaccine that is in the pipeline. And of course what data is telling us, and I think that was also touched in the previous presentation, we see that there's protection at birth against neonatal tetanus, and this is around 86% globally. That is in 2024, and then LMIC is about 83%, not so far from the developed countries. For COVID-19 vaccines, I think we were not so sure, the population was not so sure at that point whether the vaccine is safe for pregnant women. So the uptake here, I think I got this from WHO, in 2022 was about 27.5%. And of course, for the other vaccines, we see that the uptake is still really, really low compared to the high-income countries. And I'll switch it off again. So importance of safety surveillance of maternal vaccines. So the usual cycle, you have the clinical trials data that will be used to give market authorization for marketing authorization holders, and of course the regulatory authority here will continuously monitor the quality, safety, and effectiveness of the vaccines. And of course, from this monitoring, we expect that that data is going to inform regulatory decisions. So it is important that we have a robust safety surveillance system in place so that we are able to detect any safety issues in a timely manner. But even as we do this monitoring, and I think it has been repeated in the presentations before, that it is important that the public have trust and confidence in the vaccines that are there in the market. And of course, we appreciate the limitations. We've looked at the numbers that of participants that have participated in the clinical trials. It's usually a very small number. Sometimes we do not have clinical trial data on pregnant women, but I think that narrative is now changing. And of course, during clinical trials, there's a small sample size that is used, short duration, and it is usually very difficult to pick out rare, unexpected events. And therefore, when we expose a bigger population, we are able to collect real world data that, of course, will feed into the regulatory decisions. Another limitation is what we are observing, especially in the LMICs. We don't see a lot of reports on both medicine and vaccine use in pregnancy. And of course, we also appreciate the physiological and immunological changes that happen during pregnancy, that of course, this would have an impact on the response on the vaccine. So I think I already stated that it is very, very important that we have a robust post-authorization safety surveillance system in place to pick up those safety concerns. Objective of a maternal vaccine safety surveillance. So one, I think I've mentioned that in my previous slide, we want to detect rare, serious, unexpected events. We want to monitor pregnancy-specific and neonatal outcomes. I think those have been comprehensively covered in the previous presentations. We want to assess the benefit-risk balance in real-world use, because of course when the benefit risk is unfavorable, then that vaccine has no business, or that medicine has no business in the market. And of course, you want to continuously maintain public trust and confidence in whatever we're implementing. There are WHO policies that have come in place, including guidances and manuals on how to conduct active surveillance for vaccines, and I think I've captured that in my next slides. I think it will be a slide after this one. But some of those types of safety surveillance systems that we have in place, in the LMICs, we are highly dependent upon the passive surveillance systems where the healthcare professionals and the public report to the regulatory authority on events that have been detected. But there's also the active surveillance systems where you're looking in the context of vaccine, the vaccine of interest, it is exposed to pregnant women, and perhaps you'd want to follow them up actively and document any events that occur. And then, of course, the pregnancy exposure registries. I'll talk a little more about that and what we are doing. You can also use population-based maternal health research platforms. We can use electronic health records database, and of this one, we are really advocating that if we have national systems, it would be good to leverage them on that because of sustainability. Resources are, we have constraint in resources in terms of, especially when it comes to implementation of active surveillance systems. So some of those key safety outcomes of interest that we'll be looking out for when we're implementing the safety surveillance methods. For maternal, these are just but examples. You'd have your local and systemic adverse events. So injection site related, so probably pain, swelling, redness, and what have you. And of course, systemic, probably you'd be looking at the headaches and myalgia and so on and so forth. And of course, what would be important now is the pregnancy complications that may arise. And then, so miscarriages, maternal deaths, and so on and so forth. And of course, now when you focus on the fetal and neonatal outcomes, you may have the stillbirths, the preterm births. We have exhaustively talked about such outcomes. So again, just emphasizing on what I stated is that it is important to have effective maternal pharmacovigilance systems in place. And what is key here is that it should be a system that is able to track the maternal vaccine exposure, monitor throughout the pregnancy, document the events and outcomes for both mother and of course when the baby is born after delivery. So 3 months, 6 months, 1 year. So I talked about WHO guidances that are already available. Those are the 3 WHO guidelines that are available for active surveillance. And I think what we used during the COVID-19 vaccines was very helpful. It was the white manual. And this can also be used for safety surveillance of maternal vaccines. So this is just a general outline to show you what a vaccine safety surveillance cycle looks like. So initially you have the adverse events for immunization detection. This can be done by the healthcare professional. It can be done by those who have received the vaccines or even the caregivers. And then of course the regulatory authority will be notified through standardized reporting forms. Again, the reporting can be done by the healthcare professional, the vaccine recipient, and the caregiver. So in Kenya, we have a number of tools that can be used. We have the electronic reporting platform. We have the paper-based manual reporting forms. We also have an app that can be used, but we also have a dedicated telephone line where the vaccine recipients or the caregivers can actually call the regulatory authority and report. So I'm sure this varies the different countries. And then, of course, for any event that was reported as serious, there is investigation that happens. In Kenya, we have counties and sub-counties, so we have trained them together with the EPI. These investigation teams are a multidisciplinary team, and what they do is get to have more information on this event. So it could include interviews that are conducted with the healthcare professionals. It could include interviews with the patient if they had been still admitted. And then now we use a WHO standardized form where all this information is collected, and then now it is forwarded for causality assessment. This event that has been reported, is it related to the vaccine or not? And of course, the reporters expect that we give them feedback. So at the national, county, province, state, whatever you call it, would do such communication back to the healthcare professional. I can see my time is up. But some of those challenges that we are encountering in safety surveillance is underreporting, especially for passive surveillance. There's fragmentation of data systems, whether it is from the facility level, at the program level, at the national level, regulatory authority level. And of course, there's also limited local data. As I say, there's very poor reporting of vaccine, of AEFIs to the regulatory authority, especially for maternal vaccines that are even currently in use. And then, of course, the limited regulatory and technical capacity, because then the data that we receive at the regulatory authority needs to be analyzed, and we need to make regulatory decisions around it. We need to do signal detection, management activities. And of course, there's a lot of misinformation, disinformation, and resource constraints that I talked about, especially when you want to implement the pregnancy exposure registries or any other active surveillance method. So what are the opportunities that are available? First of all, because of the fragmented data systems, it's important that we forward towards integration of the national PV systems with the maternal, newborn child health systems that are available all the way to the facility level. And then it's important also to strengthen surveillance. I said we mostly rely on passive surveillance, but active surveillance is resource intensive, but it is important to also strengthen that. And then the promotion of use of electronic digital reporting tools. Of course, we'll also appreciate that it's important to have standardized data collection tools. Strengthen stakeholder engagement all the way before even the rollout of the vaccine, throughout the rollout of that vaccine, and the entire life cycle of the implementation of that vaccine. And then, of course, continuous capacity building, whether it is the regulatory authority on how to use this data for the regulatory decision making, to the healthcare professionals on how to detect, how to report these events, and of course, adoption of harmonized data collection tools. So we have Gaia, and we also have WHO, which has come up with those tools. So this is just for us to appreciate the Gaia case definitions that we can use for neonatal case definitions and also obstetric case definitions, but also the WHO standards or indicators that we can use. So standardized tools will help in terms of data that we collect. So this is an example of the partnerships that we've done. So Kenya and Ghana came together. This is the National Regulatory Authority, so PPB for Kenya and Ghana FDA Ghana. And then we have our technical partners, AUDA NEPAD. We have the AU3S Safety Surveillance Program. We have our technical partners, WHO MHRA, and of course funding from the Gates Foundation. And then for these two countries, we have research institutions. There's Dodowa and Kintapo from Ghana. There's KEMRI, Wellcome Trust, and KEMRI LSTM. And together, we are actually planning for maternal immunization safety surveillance for RSV. And this is a piece of work that started in sometime in 2023. And we are actually in the phase 1 of planning, and we hope to implement the phase 2 probably 2026 to 2028. And of course, the outcome here is that we hope that we would have strengthened PV systems, not only in Kenya and Ghana, but this is something that will be rolled out in Africa. We now have AMA that is in place. So we talked about evidence into action, and this is one of those things that we are doing. So key takeaways, we agree that maternal vaccine safety is essential. It is non-negotiable. We're dealing with a vulnerable population. We also agree that the systems must capture outcomes. I have shared those harmonized tools and standards that we can use, but very importantly, there needs to be linkages. Whatever we are doing for the mothers, we vaccinate them, but it's also important to have the linkages between the mothers and the infant outcomes for us to make good regulatory decisions. And then, of course, a combination of passive and active systems. LMICs rely a lot on the passive surveillance, and sometimes you'd find that we actually don't receive so many reports because this is dependent upon the voluntary reporting for those groups. And then strong regulatory oversight. I've shown you an example of partnerships, so collaboration is very important. And of course, a resilient surveillance system is key. So thank you, that's the end of my presentation. And I think just following the theme of this conference, healthy babies do need healthy mothers. Thank you.
Thank you, Martha. Okay, so now moving on to global financing. So I'd like to invite Ignacio Esteban. So Ignacio is a pediatrician and public health professional trained in infectious disease, epidemiology and vaccine policy. At Gavi, he leads the maternal immunization efforts, including future GBS and RSV vaccines. And it's going to be very interesting to hear from you in the current global funding environment about your thoughts on that. Thank you, Esteban.
Thank you, Simon, and hi, everyone. Very happy to be here, and thanks so much for the invite. I think as we all highlighted yesterday in the Menti, financing and sustainability is also one of the key topics that we should be discussing. I believe that in the same way that the GBS community has been looking into correlates of protection, effectiveness studies, surveillance, we should also be thinking ahead in terms of financing and not wait until the vaccine is available. And also, I heard my name 4 times this morning, so maybe that also speaks to potential importance for this talk. So with that context, one of the key topics I would love to discuss with you is what does the model for Gavi look like and why it could be so important for a future GBS vaccine. What are the learnings from our vaccine investment strategy? Thankfully, GBS has already been through our process to identify new products. So there are many key drivers for financial sustainability that we have assessed already. What does Gavi 6.0 look like? What are the country vaccine budgets and some of the things that Simon mentioned on that slide where we divided programs? So I would love to speak to that a little bit more. And then I would love to finish with one slide on why I think we should remain optimistic for the years ahead. So as you may all know, Gavi is a private-public partnership that started 25 years ago with this model that is a pioneer model based on co-financing and transition that enables countries per their gross national income to start at the initial self-financing stage, and when and if their economy grows, they start increasing their share of the vaccines payment. So when they start, they only pay a little cents for each dose they procure through us and UNICEF, and when and if their economy improves, they start increasing the domestic resources they pay for the vaccine procurement, so that hopefully one day they're able to graduate from Gavi, as already 19 countries have done so. And thankfully, we know now that the model works and very well. Over the past 25 years, we've seen countries graduating from Gavi and spending more from their own money on vaccine procurement once Gavi leaves, and having been able to do those successfully. And in terms of impact, we could name many programs here, but in terms of children that have been immunized, over 1 billion single children have been immunized through Gavi doses. We have seen coverage of key vaccines going up, even higher for some low and middle income countries than high income countries. We've seen 19 countries graduating from Gavi, and I think it was also mentioned today, Indonesia has not only graduated Gavi, but also now became a donor from Gavi. And as many programs that could be mentioned here, HPV is one of the success stories, but hopefully we could have GBS here over the next years. And as I mentioned to you, GBS already went through the vaccine investment strategy. This is the process that the Alliance has to try to identify new and underused products that we are currently not investing on. So what we are trying to answer here is, should we invest in GBS or should we use that money to invest in Shigella vaccines, for example? So it's a process we conduct every 5 years through a transparent methodology, and the most important reason is why we do it every 5 years and why do we look into products that are still not available. It's because we are trying to send signals to everyone, to manufacturers, to donors, to countries, that some products have been highlighted that may have a strong demand and strong impact in Gavi countries. It's a series of board decisions and consultations and modeling that end up in final board decisions, and that could lead to new vaccine programs such as the July 2025 decisions to start the RSV maternal vaccination program, or a global stockpile such as the one we're designing and about to start now for Mpox, and also some learning agendas to try to support those programs. And all of this decision informs Gavi's strategy and how much funds we're going to need for our next strategic period. As you can see here, many vaccines and antigens have gone through the VIS and have been introduced in our portfolio, and thankfully in the VIS 2024, 2 vaccines that are already under the program design, such as RSV and Mpox, will be included in 6.0, and GBS was already approved in principle, and I'll be talking about it a bit more today, but also tomorrow in Plenary 7. When it goes through the VIS, the vaccines go, what we try to capture is the full value vaccine assessment, what could be the impact from many, many perspectives, not only from health impact, but specifically for this talk, there are many financial and cost-related criteria that we take into account in order to make decisions, such as value for money, what is Gavi comparative advantage from the market side perspective, what would be the economic impact, what would be the cost from delivery, from procurement, and what will be the implementation cost as well. And we compare this to other new potential investments, but also to the current portfolio, to better understand where a new GBS vaccine would land, for example. So for this analysis that we presented to the board in June 2024, we did a demand forecast analysis, thinking how many doses would be required. So some of this is outdated assumptions, but it's still to give you an idea of what we try to achieve, show how many doses we would have to require, how much it would actually cost based on many assumptions of the products that will become available, and what would be the delivery cost for this vaccine. So try to understand what would be the overall cost for GBS, but for other programs as well. So as I was mentioning, some of those graphs are now outdated because it was information we had in 2023, 2024, but I wanted to share with you what were our learnings from that analysis. In terms of the demand forecast, that would have immense impact on how much the program would cost. Obviously, the country scope will be very important to us. At this moment, it's all Gavi eligible countries, but there may be programmatic considerations that may change that in the future. We'll also be looking into what would be the country adoption rate. We're in a very constrained scenario where countries have to deal with multiple priorities at the same time. So we'll have to assume if they haven't introduced HPV, if they haven't introduced malaria, that those will probably come first. What would be the target population? We know it's pregnant women, but we look into the weeks of gestation, and that has a lot of impact in the coverage we can assume, and the acceptability in the pregnant women as well. What would be the year of introduction? Gavi only invests in vaccines and starts a program where certain conditions have been met. That's why the decision on GBS is in principle, because we still obviously need a licensure of a safe and effective vaccine. We need a WHO safe recommendation and WHO pre-qualification as well. Vaccine coverage and uptake will also be key. We'll need to look into what would be the best coverage assumption. We talk about ANC4. We also have ANC model for weeks of gestation. We have tetanus coverage, but hopefully when we revisit this analysis, we can look into RSV as well. The product presentation, multi-dose vial, to have it available will also be a key determinant. And in terms of price forecast, obviously, hopefully it will depend on how many products are available and what will be the year of introduction. Tier pricing strategy that hopefully will be available when GBS is licensed. The volume of the high-income countries market, we really need to understand to what extent GBS will be a dual market. what would be the Gavi agreements with manufacturers, and hopefully manufacturers will also have an equitable access clause on affordability. And delivery costs, Simon talked a lot about it, so I will not go into it, but I would like to highlight the last point in combination with other vaccines, and this was also highlighted earlier today. We have maternal tetanus in low-income countries. We don't have pertussis, but that may come as well. This is being revised this year at WHO SAGE. We know RSV is coming, so we really have to look into what will be the added value and also the added cost of adding a new vaccine and the feasibility that it will bring in low-income countries. This is all information that is publicly available, but this is just to give you a sense of what we look into when Gavi decided to make an in-principle decision on GPS. This is our healthy market framework where we try to identify if there's anything for Gavi to do and what would be our potential comparative role. Just to give you an example, BCG is a vaccine that every country has introduced, and it's very cheap already, so there's less a role for Gavi to play there. But for GPS, it was highlighted that certain conditions are there that probably speak to a healthy market, but others are still considered challenging, and there's probably a role for Gavi and many partners to continue engaging. So we know that there's going to be a need for phase 4 effectiveness study. We don't know what will be the implication on SAGE on that yet. And we also know that we still don't have a strong demand signal from countries. That would also be very important. So overall, our market shaping experts did not identify a strong challenge for the GBS market. Thankfully, this is good news, but still there's a lot of work to do to try to solve a lot of these issues. And in this context, starting with 2026 now, Gavi is starting its 6.0 period, and there's a couple of changes that I would love to share with you. So there are 4 principles that are driving most of these changes. And the most important, to summarize what we see on the slide, is that we want to put countries at the driving seat. We want to change who is the owner of most of the decisions so that they can decide what is best for their countries and how to use these funds. And as you might have heard, in June 2025, we had our replenishment meeting, and it was a very successful meeting where we reached almost $10 billion for supporting immunization in Gavi countries for the next 5 years. And I believe this is the highest target we have ever achieved. However, our target was 12 billion. This means that countries and supported by partners will have to make decisions on how to prioritize those funds. And that's also one of the key reasons why you're seeing some of the changes that I'm mentioning today. So one of the changes we're making is vaccine budget. This is country vaccine budget to try to give them visibility to countries how much funding they will have available for the next 5 years so they can decide what to prioritize. One cash budget to decide how to support their programs in terms of health system strengthening, technical assistance, or CSO support. And we also have simplified our system to try to make it easier and less burdensome to countries. So for example, this is how it used to work until Gavi 6.0. Based on their capacity to introduce, they would be able to apply to any vaccine and to the amount of doses that they wanted to. However, this is changing in this funding constraint scenario where we have more vaccines available as well and a higher target population as well, where countries will need to decide based on a specific ceiling for their vaccine procurements. So this is the slide that Simon was mentioning earlier today, where in terms of their health impact, in terms of the regional spread, we have divided vaccines, into guaranteed budgets that are forecasted in the number of the countries we'll see very soon, how much funding they have available for the next year. And then we have diseases that will be on a discretionary budget. There is also a number of US dollars that country will see, and they will have to decide how to use them and which vaccines to prioritize and which vaccines they will have to continue self-financing with their own resources. For example, RSV was included in discretionary budget, not because it's not critically important, just because no country has introduced yet, and for my inter-country equity, there are other programs that would have to be prioritized first. So just to finish, after some, not some optimistic news, but this is one slide on why I think we should remain optimistic when we think about the financial aspect and the sustainability of new GBS vaccines. So, first of all, there is an in-principle decision from the board, and when I say the board, this is UNICEF, Gates Foundation, WHO, Gavi Secretariat, but also countries, manufacturers, researchers, donors that have supported that GBS is going to be very important for Gavi eligible countries. So far, every time that the board made an in-principle decision, when they revisit that decision once all the data was available, they supported it again. Last year, we were in a very difficult time where having to make very tough decisions, and we brought to the board, because those products were ready, the decisions to initiate an Mpox stockpile and RSV maternal vaccine. And the board, still in this very difficult context, decided to approve it. So I think that should remain optimistic. One of the reasons why we should remain optimistic for the years ahead. There is a strong demand, a strong signal coming from the Gavi board, and hopefully when all the data is available to make that decision, they will be able to support it. We know maternal vaccination platform exists in every country. Gavi has not yet funded a maternal vaccine, but that will change for RSV. But we know that this maternal platform exists, and they do very well, obviously with some limitations, but all of that has been self-financed mostly by countries. And that is something, thinking about sustainability, that should also be considered. In these next years, we will have to see greater country ownership, not only because of the models, but also because of this financing scenario we're seeing. The countries will have to start spending more from their own money in procurement of vaccines. So hopefully in a few years from now, we have seen the changes and the progress made by countries. So adding a vaccine will be probably and hopefully more streamlined. We'll be also learning of how the ecosystem of partners change. The current scenario we're living now, where countries have to make very tough decisions, will also bring a lot of learnings on who should be doing what and what should be countries' role as well. So when we revisit GBAs in a few years from now, hopefully there will be some learnings and a new ecosystem of vaccine procurement as well. We will learn from RSV. As I mentioned, we're now working with all partners to trying to design a program that is fit for purpose, and hopefully once the multi-dose vial presentation is available, we'll be able to introduce it very soon in countries. This is expected by 2028, so hopefully once a GBS vaccine is available, we'll have critical learnings coming from low-income countries. The other potential good news is that based on the timing we know now from the manufacturer and the policy and the regulatory pathway, GBS is not expected for 6.0, but will most likely be at the end of 6.0 and Gavi 7.0. So GBS, once available, could also benefit from a new replenishment in 5 years in a totally different context. And my last point is that the global context might change. We're now in a very difficult scenario, but I think we should all remain optimistic that things can change, more donors could come to Gavi, and hopefully be able to support GBS and other vaccines. Thank you.
Thank you, Ignacio, for the really great talk. Okay, so finally, I'd like to invite Professor Violet Naanyu to come and give her talk on equity. So Violet is a social scientist on the PROTECT project, and she leads the work package on vaccine confidence, and she has extensively used community engagement research and human-centered designs. Thank you, Violet.
Thank you very much. I'm literally between you and lunch, so I think I'll take a shorter time than I had been given. Is it this one? Good. So the other thing is this. Most of what I'm going to say has been said by many people in different ways. So I'm only going to tell you stories because I'm a storyteller. First, I was asked to talk about access and equity. And so I like starting with definitions. I'm a teacher. So when I think about access to maternal vaccines, I think about, does she know about it? That has already been very well illustrated by the family we just watched last. Does she know about it? Has she ever heard of it? Is she aware? Does she even have knowledge about it? So before you talk about acceptance, we have to talk about awareness. Then the next thing is acceptance. Then acceptance is all about willingness. I've gotten to know about it. I'm willing to go for it. And then the next step is, reach. When we talk about access, sometimes we talk about distance. It's not just about distance. It's about getting there. It's having fare to get there. Yeah. It's even having permission from my husband to get there in some of our contexts. So we're talking about ability to reach. And then affordability. In some of the facilities, you pay a little fee to get your, registration. During the COVID time in Kenya, there were some points where you had to register yourself somewhere. Some data we collected recently at the Aga Khan Center of Excellence, Women and Child Health, when we asked them about facilitators to taking up the COVID vaccine, they told us about a platform where I had to go and register. It was too complicated for me. So it's not just about affordability, it's also about those types of logistics. And when she arrives, did she get it? Did she receive it? Was she well received? Were we hostile? Was there a stock out? So these are realities when we talk about access. So I would like us to think about all those together when we think about access. Then the other key thing, is about equity. And again, because we don't have much time, oftentimes when I talk about equity, you can't help talking about equality. I'll tell you a story. My husband, Richard Aya, keeps pigs. During the Christmas break, when we went home with our children, there was a pregnant mother pig. And we were told, you might be lucky, she might actually deliver while you're here. And the children were so excited. So the farm manager quickly called us when he heard that the pig was getting babies. And we were all excited, how many, And she gave birth to 10. And out of these 10, a few were weaklings. And I remember my daughter Maya, the next morning when we went and they were trying to breastfeed from mother pig, some were on the side, they're little, they're so cute, they look so vulnerable. Some were really going for the mother's breast and kicking off the others. And my daughter asked, who's going to help that one in the corner? Because she's tired, she's weak, she's not moving. And one of them looked a bit disabled. This is about equity. Can someone step into the pen and pick that little one and take it to the mother pig's breast so that it gets its first colostrum? So equity is about looking at people, not just about equality, that we're fairly distributed. I have an aunt who keeps chickens. If you go with a chicken feed and you spread it in there, a lot of chickens will eat, but some may not eat. Maybe there's a chicken in the coop in the corner, just sitting there quietly, it's unwell, it's unable. So there will be people in our systems who require us to distribute that which we're giving out differently because of their specific needs. And that's what equity is all about. So when you look at vaccines, again, a lot of this has already come up. To me, as a bioethicist, I look at it also from the moral angle. We are asking about, SOPs, guidelines, structural systems, health systems that are not working for some of our mothers and some of these families. You find that there was an example when we had home-based testing for HIV. I work in Moi University in the western side of the country, and the AMPATH Research Consortium has been working there for many years. When we started the HCC, we employed so many research assistants, and we sent them door to door. And in one of the areas called Port Victoria, where we have very many marginalized families, it's an area where we also have flooding now and then. There were mothers who were pregnant. We were introducing PMTCT, and we got money and we decentralized care to 5 kilometers distance to the villages to make sure every pregnant woman could get PMTCT. We went there, did the counseling, but some mothers didn't show up. So I remember Professor Joe Mamlin, who started the AMPATH program, calling me and saying, Violet, you're the social scientist. Can you go and find out where a mother would know that she has HIV and there's something we can do about her baby and she doesn't show up? Guess what I found out when I went there? because of time, I won't go into the story. There wasn't a single woman, poor, illiterate, marginalized, you name it, all the things they say, oh, ni mjinga, haelewi, she's just illiterate, that's why she's not coming. No, there wasn't a single woman, irrespective of social strata, who understood when it was explained to them in their language, in the simplest way, what PMTCT was. There wasn't a single woman who wasn't willing to walk the whole day to get to the facility that was offering PMTCT. So we need to think about barriers that have nothing to do with individual and psychological level. What can we do about structural health system ones? Socioeconomic barriers. What can we do about cultural barriers and the other things? All right, sorry, I need to go quickly. And so I started thinking about how do we prioritize equity in vaccination efforts? And I was thinking about the social justice lens. Here we're simply saying you and I and everybody else, we hold hands and try to alter all and every practice that is increasing this, differentiation and also increasing inability for us to treat people equitably, not just equally. So that every mother can actually access this care when they need it, they can access the vaccine when they need it. We need to go upstream and look at the root causes of these inequities. And then, like in Kenya, some of the places we work, if a mother shows up at 11:30, she's told, oh, we finished the immunization. We do it from 9 to 11. I mean, what are you going to, she walked so far, she couldn't afford a motorbike ride. So she's a little bit late. But the nurse is also doing 1,000 other things. So there's a workforce issue. All these things together, we need to be practical, very pragmatic about how do we do this, and then how do we empower these women to know their rights and also know what they can be able to do, what's within their hands, and where they can scratch themselves, and we can scratch the rest of it for them. So I conclude by saying, let's do what is right, not what is easy. It's not going to be an easy ride, but I think from all the presentations we've had, from the issues about nations should be more self-reliant vis-a-vis donors and things like that, the landscape has changed, but each of us can do something. Let's see how we can reach the last mile applying the human rights perspective. And let's remember it's a journey. It's not going to end here, and that's why I like these conversations in these conferences and other spaces, because we continue talking about it and trying to do something about it from our little pockets. I like what Martin Luther says here. Our lives begin to end the day we become silent about things that matter. I think we all agree what we are discussing in this conference matters. Let's all do our part from our little corners. And I saved 7 minutes.
Thank you, Violet, both for being very quick, but also for ending on that really important and positive message. I'm now going to hand over to KP, which I realise is a bit of a hospital pass with the amount of time left on the clock.
Yeah, thank you very much, Simon. So we just have a few minutes. I've been told that we would cut it off. And for saving us 7 minutes, I'm just going to ask you one little question. So with regards to equity, who really drives the equity when we talk about maternal immunizations and GBS at the community level and within the health service or health sector? We often talk about equity. Everybody knows it, but who should ensure it? Please hold that, and then we'll come back to you. And then we'd like to give a bit of time to Ignacio with regards to funding. This has been mentioned a lot here, and it came up in the Menti map. The point is, Gavis 6.0 is now talking about discretionary budgets and also guaranteed budgets. In the discretionary budget, we have something called different vaccines. So can a country decide that, well, we're not going to give malaria vaccines now, but we'd rather use the money for, say, GBS? Is that the assumption? Can you explain a little bit more the discretionary budget and then the guaranteed budget? So we'll take these two, and I'll come back to Michelle and Martha.
Thank you very much. I've been asked who is responsible in ensuring equity, and I'll take you back to the piggery. We started asking who's responsible for each of those 10 piglets, who's going to make sure each piglet has a right to life. My husband has a role as the owner of the farm, so does the farm manager, And so do the farmhands who take care of the piglets and make sure they've been fed and all that. So what I'm trying to say is the actors are many and across the board. I think we have them at global, at national. In Kenya, it would be at county and also at the tier 1, the community level. And here, when I think about also others, like the civil society, we need advocates for mothers and for the issues of maternal vaccines. We need researchers like you and I to do the work we are doing around this conference and beyond. We need the pharmaceutical companies because, and Gavi and others, to stand up and say, there's a place we can fix this gap. And then when you think about the national, like I think about my country, I think regulators, as has been very well explained, and then professional bodies, and also the healthcare providers. One of the things that has come out of our vaccine confidence work in Protect, one of the things that women keep saying, if my provider tells me, I trust it. If my provider explains it to me, I'm likely to take it up. So this is a fact that we have all these actors, all these players. If we're able to step in and see how we can say every mother needs to be given time, like I said, awareness to understand. We want to package, even if it's in a mobile way, go to those outreach, those marginal areas and take the vaccine. We need to make sure if it's a national regulatory bodies, if it's licensing, English is a bad language to me. But, how are we, and that has come up today, it's too many years waiting sometimes for things to be approved or too many months. Is there a way we can deal with this? So I think the actors are many and everybody needs to play their role.
Thank you. Ignacio?
Thanks, KB. And yes, on the first question on equity, I totally agree. There are multiple partners and everyone is involved in this and everyone has a role. From the Gavi and global perspective, our main objective is to make the products available. For diseases like GBS or RSV, we saw it also for PCV, Rota, high-income countries will introduce first, and that is an assumption that I think will remain over the next years. But what we have to work on is to trying to reduce the gap on the number of years until the products becomes available for low-income countries. And on the country vaccine budgets and the example you gave on discretionary budget, that is correct. We know this change in the Gavi model where we're asking a lot of countries to start making very tough decisions or prioritizing or optimizing their portfolio is difficult and maybe a change in the rules of the game. But, and we know some countries will be very ready because they have a very strong NITAC to do so, and other ones will need more support. So in terms of discretionary budget, you are correct. Depending on their transition status, they will, and the availability of funders, they will have to prioritize what are the programs they would like to continue and which products they will like to have Gavi support and co-financing support, and which are the new vaccine introductions they would like to see over the next years.
Right, thank you very much. And now to Michelle and Martha. So Michelle, you spoke about MENA work that has been done in the last few years, fantastic work. But I'm thinking about sustainability now. Beyond the researchers and the group that started, who are the main people that are supposed to be using the output that has been generated out of MENA, and how sustainable would that be? How do we get on other countries to utilize the outputs that have been generated in the last 2-3 years?
Yeah, so it's right. I mean, this started with the 9 countries, but I think by no means is it going to stop there. And I think this was also specifically kind of financed through the Gates Foundation. And so I think it really is for countries to step up, and I think for regions. And I think we purposefully chose countries represented in different regions. And I think it's for those countries also to be supportive of those kind of surrounding countries. And I think really to look for champions to stand up. I think it's really not always for the researchers, it's for others to really stand up. We've seen, the kind of parent videos, so I think, for communities and really to advocate in terms of moving this forward. So I think this is just a stepping stone, and I think MERN is just kind of a platform. So our work has really been focused on maternal immunization as a platform, and I think then we'll be bringing in as certain kind of pathogens and certain vaccines come through, those will then also kind of be able to be taken forward. But I think, once again, I think as with equity, I think it's everyone's responsibility to take it forward.
Right, thank you. So, Martha, you mentioned a lot of issues that's got to do with maternal reporting, and indeed you alluded to this, that there are few reports when it comes to maternal immunization. Indeed, in Ghana, we have about less than 50 reports from mothers after immunizations in the last 20 years. And the question is, if we were to get into actions, given the evidence we currently have, which three main things would you think that we should deal with to increase reporting and to ensure that the data that we get is utilized and communicated appropriately?
Thank you so much. I think the same picture is replicated in most LMICs. Yeah. So very, very few reporting for maternal vaccines. I think I mentioned some of those things that we need to explore. First of all, we really need to sensitize, train our healthcare professionals on these events, because I think sometimes it's the awareness bit that is missing. Is this normal occurrence? Do we need to do this reporting? And I guess it's understandable because it's kind of confusing. Is this the pregnancy sort of issues versus an adverse event following immunization? So aside from capacity building, I think it's also very important that we adequately prepare even before the rollout of that vaccine. We need to do stakeholder engagement. I think we've talked about those who are in the policy making avenue, but also right down to the community, because now the public is getting more and more aware about the vaccines they're being given, more aware about the medicines that they take, and they are good source of reports, whether they're doing it on social media. But then now that also means that a country needs to have those platforms that are friendly to the consumers to do the reporting, whether it's a dedicated toll-free line and what have you. So more of boosting the reporting. There's something else about active surveillance. I mentioned that it is resource intensive, but when you have people, when you have sentinel sites perhaps, or you've established registries, then there's a lot of focus in terms of the healthcare professionals, the research assistants who are there. There's door-to-door visits, there's active follow-up on events. So that also boosts a lot. I think we experienced that during the COVID-19 vaccines. The active surveillance that we conducted through cohort event monitoring, we received so many reports compared to the passive surveillance. And then, of course, I know you mentioned 3, but the last one is we cannot overemphasize the importance of collaboration. We cannot overemphasize the importance of harmonization. I think there are tools that are readily available, the WHO, Gaia, indicators that are already in place for us to collect meaningful data that we can use for decision making. We need to implement those tools. Thank you.
Thank you very much. So we're going to ask for questions from the group, but it looks like we've run out of time. The panelists will be available to answer any of your questions. Shall we put our hands together for them? Thank you very much for presenting to us, and thanks for answering the questions.